Welcome to the Parkinson Foundation Expert Briefings. The event will begin shortly. There will be a short introduction by our moderator, followed by today's presentation. After the presentation, we will address any questions from our web audience during a Q&A session. Please note that questions can be submitted by clicking on the Q&A icon in the black banner on the bottom of your viewing page. Due to our limited time, we can only address questions that are most pertinent to the topic. I will now turn this event over to today's moderator.
Hi there, this is Jim Beck. I'm the Chief Scientific Officer at the Parkinson's Foundation. And getting my video started, I happen to be from a remote location today. I'm at the Atlanta headquarters for the Centers for Disease Control and Prevention. And I'm talking about trying to understand the prevalence for Parkinson's disease and other diseases. So it's very apropos that we're dealing with Parkinson's today for everyone out in the community. And this is our second time we've done a video session for our 11th expert briefing series. So I'm really glad to have an opportunity for everyone to see me and we have a chance to interact with our new format. It's going to be, as before, another great event. It's a little bit of a different process for those of you who are new to using our new webinar format. I just want to kind of advance for you. This is just a slide to show you what you probably are viewing at the bottom of your screen. And I'm just going to annotate it a little bit because that's something we can do here. It's quite nice. Draw. There's a couple buttons for you to take a look at. One is a chat button, which is something that will be important to take a look at. There will be some links that'll be pushed there. You can't actually do the chatting, but what my colleagues can do is push links regarding CEUs and other credits, which are going to be important. And also we have a Q&A, which is where you're in the audience, you've got questions. This is how you submit them for us to know what's may be important for you to do. Remember, if you are a health professional and have registered for our expert briefing series as such, then you can also be able to receive CEUs as part of this process. So take a look into the chat. You can see where you can do that. You can also download the slides for this particular presentation. So take a look at chats and with which to do that. One of the cool things that we can do as part of our expert briefing series here is really understand our audience. And so what I'm going to do right now is push a poll to everyone here to ask who you are, who is out in the audience right now. We have over 650 people who have registered. So take a look. There should be a poll on your screen. Select whether you're a person with Parkinson's, whether you have someone with Lewy body dementia, you're a care partner. And we'll keep this up for a few seconds. We've got about half of our 660 people have responded. A lot of people are care partners who are responding. Some large number of healthcare professionals, which is great to see. I think we're going to have a lot of good information by Dr. Quinn being presented today. So I think give it just another couple seconds. We've got ready to go. And here we are with the results. By and large, most people are care partners for people with Parkinson's disease. A large number of people who are health professionals, as you would expect, from a variety of backgrounds, and people with Parkinson's. So let's move on to our next poll, if we can. And then true or false? Is dementia the same thing as Alzheimer's disease? So let's give this another 30 seconds or so. People responding quickly, which is great. It just indicates that people are very in tune to how to use this process and have a definitive answer. I think we see well over 450 people have responded. Another 5 seconds, we're going to stop the poll and push it live. Okay, colleagues, there we go. Yes, we'll be able to answer this question. Dementia, is it the same thing as Alzheimer's disease? Our audience thinks no, that it's not the same thing as Alzheimer's disease. So let's move forward. Dr. Quinn's keeping track of this. These are his questions. So Another question for you, true or false? Dementia is rare in Parkinson's disease. Okay. We've already got 400 of our 700 attendees have already responded. So let's see what we have. People are pretty definitive about this as well. Interesting how it's going to turn out. Okay, let's push it live and see what we have the response. By and large, people, the audience believe that dementia is not rare in Parkinson's disease. Okay, we'll find some more about that. So I think we know the answer. That's why we have a whole webinar on this. And then our final question, true or false? Dementia caregivers are at an increased risk of poor health compared to their peers. All right. Wow, people really fast on the draw. Well over 500 with just 20 seconds in. And again, I think it's a landslide in the polling here where people feel. And our audience believes that true dementia caregivers are at increased risk of poor health compared to their peers. Okay. By and large, that's the overwhelming response. Okay, so I think this is a good segue now to introduce my good colleague, Dr. Quinn. Dr. Quinn is a professor of neurology at and a neurologist at Oregon Health and Science University and the Portland VA Medical Center. He's also director of the Parkinson Center at both of these institutions. And he's previously served as the core director at the OHSU Alzheimer's Center. Of note, OHSU happens to be one of our centers of excellence, and Dr. Quinn is heavily involved in that. Dr. Quinn devotes his time caring for patients in a clinical setting and also performs research that focuses on treating and preventing cognitive decline and dementia in individuals, including patients with Alzheimer's and Parkinson's disease. Specific research projects range from animal studies, testing experimental treatment strategies, to clinical studies evaluating biomarkers and interventional treatments. So Dr. Quinn's on the screen right now, and it's my pleasure to introduce him to your audience. Dr. Quinn, I'll turn it over to you.
Jim, thanks very much. And thanks for that nice introduction. Thank you for inviting me to do this. And thank you everybody for signing in. Let's see here. I think, do I have control of the slides yet? Oh, I need to click. There we go. Okay, I don't have any disclosures relevant to this discussion. And I think it's always good when we're talking about this topic to clarify some definitions. It looks like my poll questions were a little too easy. Everybody was on the money with 3 questions there, or almost everybody. And I often, though, when I go out in the community, I get questions about what's the difference between dementia and Alzheimer's disease. Are they the same thing? And then questions about other forms of dementia. So I wanted to start off by just trying to clarify what each of these items is. So dementia is a broad term, sort of an umbrella term that covers a lot of these different conditions, and it refers to impairment in thinking that is severe enough to actually interfere with daily activities. And by daily activities, I mean the ability to work, the ability to drive a car, the ability to keep appointments, to manage finances, to cook meals, and that sort of thing. So we reserve the term dementia for when thinking problems are severe enough to interfere with those things. There's another term that is used with increasing frequency in medicine and in the area of Parkinson's disease, and that's the second term of mild cognitive impairment. And what we're trying to capture here is the idea that there are some other instances where people have a thinking impairment. It's more severe than what is the thinking changes that occur with normal aging, but it's not severe enough to interfere with daily activities. And when the thinking impairment is at that level, then we use the term mild cognitive impairment. And then the next term is Alzheimer's disease. And Alzheimer's disease is one type of dementia. And in fact, the next 3 items on the list are different types of dementia. So dementia is this broad term. Alzheimer's disease is the most common type of dementia. And that is characterized, I think most people know, by severe memory impairment as the most prominent finding, and there are plaques in the brain. You may have heard of that before. Now, that's one type of dementia. Another type of dementia is the one that is going to be of greatest interest, I think, to the audience today, and that is dementia occurring in the setting of Parkinson's disease. And we call that disease Parkinson's disease dementia. So these are patients who have a diagnosis of Parkinson's disease. They have the classical problems with movement, what we call the motor symptoms of Parkinson's disease, usually for a number of years, and then they start to have problems with thinking. They have cognitive decline, and so on. There's a second entity, and it sounds like there are at least a few caregivers for people with this last entity of Lewy body dementia. And this is a little confusing, the distinction between Parkinson's disease dementia. But in Lewy body dementia, people have symptoms of both Parkinson's and of dementia, but it's different from Parkinson's disease dementia in that in Lewy body dementia, the movement problems and the cognitive problems come on together. They come on right at the beginning of the disease. So in Parkinson's disease, when people develop dementia, it's usually after several years, whereas in Lewy body dementia, the dementia and the movement problems come on together at the beginning. And there are more points that distinguish those features, but I'm going to leave it there for the moment. Now, some years ago, it was commonly thought that dementia was not that common in Parkinson's disease, but as people have studied the problem more carefully, it's becoming increasingly clear that cognitive impairment and dementia are really common in Parkinson's disease, particularly as time marches on. Up to 50% of all people with Parkinson's disease have at least mild cognitive impairment. And when we talk about 10 to 15 years into the disease, 75, 85% of people will have a very significant cognitive impairment, maybe even dementia. But there's a term that we use in the Parkinson's, or a saying that we use in the Parkinson's world very frequently, which is, if you've seen one person with Parkinson's disease, you've seen one person with Parkinson's disease, meaning there's a lot of variability in these sorts of things. So it is common, but I don't want to give you the idea that it is inevitable. The other point I want to make here is that the dementia in Parkinson's disease is different from the dementia in Alzheimer's disease. And this is, again, something that is gradually been understood over the last few years as people have taken a closer and closer look at the cognitive changes in Parkinson's disease. So in contrast to the predominant memory problem in Alzheimer's disease, in Parkinson's dementia, people tend to have more trouble with multitasking and with planning complicated operations, things that have to do with the frontal lobes. Also, in contrast with the memory disorder in Alzheimer's disease, people in Parkinson's have more trouble with visual functions. And the dementia in Parkinson's disease is often associated with hallucinations. And I don't want to give you the wrong idea that there's an equivalence between hallucinations and dementia. You can have hallucinations without dementia, you can have dementia without hallucinations. But it is true that in Parkinson's dementia, in contrast to some of these other things like Alzheimer's disease, hallucinations are a relatively common feature. And then the last point that I think is important for a talk like this is this other item that I brought up in the polls, and that is that when we think about advising caregivers, we want to give caregivers advice about how to take care of the patient, but it's also extremely important to give caregivers advice about how to take care of themselves, because we know that the stress of caregiving is associated with a high risk of health problems in caregivers, and people really have to be very attentive to their own health, and I'll try to give you some concrete suggestions on how to do that. And the way I'm going to proceed through the rest of the talk is to run through two checklists. So the first one is a 10-point checklist, and we are going to try to touch on items that we think will help with optimizing the care for the patient. This is a checklist that happens to be modified from something from the Alzheimer's Association, but we've found it to be useful in a number of different settings, and I've modified it a little bit for Parkinson's disease here. But then in addition to care for the patient, I do want to spend a little time giving people some concrete recommendations on taking care of their own health. So there's a second checklist for the care partner themselves and how to maintain their own health. And as I go through this checklist, both of these checklists, we're going to be talking about different ways to approach the patient and the family situation of someone with cognitive impairment or dementia. And it's going to become clear that as a doctor, I can only give you so much advice, and we really need a whole team to manage this sort of thing. We always need a team in Parkinson's disease, and when cognitive impairment becomes an issue, that's even more true. So in addition to doctors and nurses, we need people outside the medical profession. We need lawyers, we need social workers, we need advocacy groups like the Parkinson's Foundation and others to help us navigate this area. So now to move into these checklists, the first item on this checklist for families is to be sure that you have an accurate diagnosis. You want to be very careful that you're not confusing dementia with some other treatable condition that can look like dementia. So you can have depression can look like dementia in some patients with Parkinson's disease. You can have an adverse medication effect that can look like dementia. You can have other medical problems that are unrelated to the Parkinson's disease per se that can look like dementia. So when you have a patient struggling with these sorts of problems, even though we recognize that dementia is relatively common, we don't want to jump to conclusions right away. We want to make sure we have an accurate diagnosis. And if your primary care provider, your family doctor is really not up to completing an evaluation, it's fair game to ask for an evaluation by a specialist. I do understand that there's some parts of the country where it's hard to do that, but that's the ideal if the family doctor is not up to it. The Parkinson's Foundation can actually refer you to centers of excellence where these sorts of things can be done. Now, when I make the point that we want to have an accurate diagnosis, please keep in mind there's not a single blood test or a single brain scan or anything that makes the diagnosis with certainty. It's made by taking all the information into the picture, the history, the examination, laboratory results, and so on. We refer to that as being on clinical grounds. But so when you go in and you ask for an accurate diagnosis, don't expect to have a single test to sort that out. But keep this in mind when you're first dealing with cognitive issues in this setting. And then try to find a physician who is familiar with dementia. And in my last item, I was suggesting if you can get a specialist, that would be great. But I have to say, if you can't get a specialist, what you really need is a physician who's really oriented to dealing with dementia symptoms and needs, people used to dealing with older people and this type of phenomenon. So I don't want to give you a list of recommendations for what to do with medicine or what to do with activity and so on in great detail. I think it really needs to be tailored to the patient. And that's why this second item is so important, to find a physician who is going to be able to help you with those sorts of things. The third item here is something that I think applies to everyone, and that is everyone who's a caregiver for somebody with cognitive impairment or dementia. This picture here looks like it's an encounter group or a support group, and I know support groups are not for everyone, but education really is for everyone. There are a lot of things to learn about how to approach someone with cognitive impairment, and this 30-minute talk is only going to scratch the surface. So you do want to get advice from a physician or a advanced practitioner about diagnosis and prognosis and treatment and those sorts of things, as we've just discussed. But you also need some legal advice. So everyone with cognitive impairment, and actually everyone who's getting older, should have what's called an advance directive. There should be a power of attorney in place for healthcare and for other reasons. That's fairly uniform. I'll come back to that in a couple of minutes. The next item is, it's represented as a single word here, but it really is an issue that could take up a whole hour-long talk, and that is, how do you communicate with a patient who's cognitively impaired? When people are struggling with their memory or with other hallucinations and those sorts of things, how to approach them, how to reassure them, how to direct them and assure their safety is a whole topic unto itself. And communication with patients with dementia patients is not an intuitive thing. It doesn't come naturally. It's not the same as dealing with a small child where you're trying to shape their behavior in a certain way. You really have to enter the person's reality a little bit, account for the fact that you're not going to be able to necessarily improve their memory over time. So communication is really tricky, and getting education on how to do this can be quite valuable. Another item that falls in the education category is safety issues, and I'm going to discuss safety issues in a later bullet point, so I'll go into them in some detail, but there's a host of safety issues that are important to get education about. In terms of where to find the education, you obviously don't want to just read anything you see on the internet, but the Parkinson's Foundation, of course, has excellent education material on cognitive change in Parkinson's disease. And I would also put in a plug here for the Alzheimer's Association. The Alzheimer's Association exists to serve people with memory disorders of all types. They've got all this great material. They've got DVDs and videos and classes, and they've got written material that they can send out to you. And they really are an underutilized resource in general. So please take advantage of all the resources out there, with these two that I've listed here being excellent places to start. This next slide here is still on this point about getting education, and pointing to the website for the Parkinson's Foundation. There's an item for PD library. You can search on particular terms. The guide on the right will come up. That's a PDF that you can download for free, and give you a lot of great information about cognitive function in Parkinson's disease. All right, so now we're on to the fourth item on this checklist, and that is the helpful recommendation to try to plan a family meeting when you realize that the patient in your family is struggling with significant cognitive impairments or dementia. And the reason is you want to get everybody sort of on the same page to help people become aware of the fact that the patient is going to have increasing needs over time. You're going to need support from other members of the family in terms of assistance. Everyone's going to need to become educated on these communication issues. And again, it's really important to make sure that the primary caregiver is not put in a vulnerable situation, and you want to arrange support for the primary caregiver. Arranging a family meeting is always challenging, and I found this next recommendation on the web recently. It says you can call a family meeting by turning off the Wi-Fi router and waiting in the room where it's located, and everyone will show up very quickly, and you'll be able to proceed. So that's number 4. Number 5. Here is an important issue about maintaining the dignity and respect for the patient with dementia. We want to be careful not to, you can imagine how you might feel yourself if you were the patient and developing some cognitive changes, and all these recommendations I've just made for the family members and the caregivers. You don't want to exclude the patient with the cognitive impairment from the decision-making process. One of the things that people ask me about all the time is whether patients who have cognitive impairment are aware that they have cognitive impairment. How much insight do they have? And that's another one of these areas where the variability is tremendous, and some people have a lot of insight in the early stages, and some people really are lacking in insight. In almost all these patients, personality and judgment is intact at the early stages. And it's, again, respectful of the patient and helpful for the whole process to try to have the patient involved in the expression of the care plan. I put this figure in to remind you most of you will remember, regardless of your political preferences, you'll remember that President Reagan wrote a letter to the public when he was diagnosed with dementia. He didn't have Parkinson's disease. Granted, it was a different type of dementia, but his letter was really quite poignant and a vivid illustration of the fact that patients in the early stages can have great insight into what's going on and can play a role in planning for the future. Now, even though that's an important element to emphasize, there is a limit to that. The limit to how much decision-making authority to assign to the person with cognitive impairment is the limit of safety. And the next bullet is about safety. So we really have to draw the line with many of these decisions around the matter of safety. And when we're talking about safety, there are some real key issues for people with dementia. So the ability to safely drive a car is something that obviously you would want to change, or you'd like to change driving privileges before somebody has an accident instead of after somebody has an accident. So you want to attend to that issue with your physician. A physician may refer you to people for more formal driving evaluations and so on. But it's something to keep in mind whenever we're thinking about dementia. A second issue is the issue of guns in the home, and patients who have cognitive impairment and sometimes paranoia and sometimes hallucinations are at risk of very severe accidents with guns. So we have to make sure that the guns in the home are locked up and inaccessible to the person with dementia if that's appropriate. A third item that I always list under the safety issues is the issue of money. You know, the world is full of charlatans who are trying to take advantage of people with cognitive impairment, and people can really have devastating financial outcomes if the family doesn't look after their finances. And then the fourth one is especially close to my heart as a physician, and that is the issue of medication. So I have a whole separate slide on medication, and I'm always struck by how slow families sometimes are to realize that they need to become familiar with the medications and take control of things a little bit. So please, when you have a patient who is struggling with cognitive impairment, even early cognitive impairment, try to get involved and at least know what the patient's medications are. Make a list of the names and the doses and confirm that with the doctor. And we don't want to strip the patient of all independence right away, but if the patient is in a phase where they're able to play a role in managing the medicines, a way to do that in a safe manner is to get one of these weekly pill boxes that you can fill up together, and then a caregiver can monitor on a regular basis. So that's the safest way to preserve a little independence, but make sure that people take their medicines appropriately. You know, Parkinson's medicines, obviously, if they're taken inappropriately, can cause all kinds of problems. And then there's other high-risk medicines that a lot of these patients are on, things like insulin and Coumadin, that can really be devastating if they're taken inappropriately. So please, that is a very, very important safety item and one that I want to emphasize very, very strongly. All right, so number 7, work out financial and legal issues. So here is a very good example of something that doctors are not very good at. So I don't really know anything about the law in this area, and I rely on elder law experts and often on our social worker to help me with these things. So this is a real good example where the team approach is important. I've put a couple of names of reputable bodies, the National Elder Law Foundation and this National Academy of Elder Law Attorneys, that you can consult if you're trying to find somebody with elder law expertise in your area. The reason I'm emphasizing this is because you want to make sure that everyone has an advance directive for healthcare, power of attorney for healthcare, and power of attorney for finances if they've got cognitive problems. There's another item that is called a POLST, that's Physician Orders for Life-Sustaining Care. Strictly speaking, that's supposed to be in the last year of life, but sometimes it's done a little earlier on. So those are important legal documents to get in place. A lot of times people will ask me, should I be applying for guardianship for my loved one? There's another legal status called a conservatorship, which means someone has a responsibility for the finances for a person, completely manages their finances. These are really rare. They're rarely needed in my experience, but sometimes they are. And that's where getting an elder law attorney involved is the rule. I didn't put bullet points up here about some of the other financial things, but there's a lot of financial planning for insurance coverage and eligibility for certain things that, again, I don't understand, but these elder law attorneys do, and some social workers do. So particularly when there's cognitive changes underway, paying attention to those things is very important. Number 8 is when you have somebody who's got cognitive impairment or dementia, you really would like them to have an ID bracelet that identifies them and gives them a number that somebody can call if God forbid they should wander or get lost even briefly. This is a very simple item that can help to make sure that a difficult situation doesn't get a lot worse. The Alzheimer's Association has a program for this, but there's other just regular medical alert bracelets that you can make up and have your cell phone put on there or that sort of thing. So that's a simple, practical piece of advice. Number 9 is to seek out support services. So I had said earlier that education is for everyone. I know that people vary in their interest in being involved in support groups and that sort of thing, but I think it's valuable to at least know what's out there. Even if you don't want to belong to a traditional support group, you want to seek out support services of some kind, somebody that you can rely on for advice and help, even respite care and those sorts of things. So we're up to number 9. Now, number 10 is sort of the transition to the next checklist. So number 10 is coming to this second point that second major point for the talk, which is as a caregiver for somebody with dementia, you want to remember that it's not just the patient you need to take care of, but you really need to take care of yourself if you're going to take good care of the patient. So some of the things that you want to think about in terms of serving your own needs is to sort of have an emergency care plan. If something happens to you, what would happen to the patient and so on. We talked about support groups a little bit. You really want to, this third bullet point, arrange for weekly personal time. You really want to try to build that into your schedule. You have to be fairly deliberate about it when you've got a family member with dementia. But if you don't, it's very easy to get burned out and be unable to take care of your loved one. The fourth item, be sure to get adequate sleep. When I see patients with dementia and their loved ones, one of the first things I do is make sure that everybody's sleeping, because you can cope with an awful lot if you get a good night's sleep. But if you don't sleep at night, everything else is harder. The next 3 items, I don't think I'll belabor. A sense of humor is always good. Having friends who can help you out is always good. And valuing yourself is important. What I want to do in the last few minutes, though, is to try to move on to this second checklist, which sort of flows naturally from this last recommendation, and that is to really try to give you a roadmap for focusing on your needs, your own personal needs as the primary caregiver. So as most of you pointed out in the poll in the beginning, caregivers are at increased risk of health problems, heart problems, dementia for themselves, brain problems, that sort of thing. So what I'd like to do in these last couple of minutes is talk about some recommendations for what you can do to optimize your health despite the stress of caregiving. I don't want to just give platitudes here. I want to try to give you some measurable, specific things that you can do. I want to give you something that's really supported by science and that has actually been vetted by some experts. And I want them to be things that you can really take action on. And I'm making these points to explain why I've come to the particular recommendations that I have here. This is, Jim was just saying that he's at the CDC today. This is a publication from the Centers for Disease Control talking about healthy brains. This was published a few years ago. There's a second iteration, and they both say the same thing. All the things that we know are bad for your heart turn out to be bad for your brain. So taking care of your heart is good not only for your heart, but it's also good for your brain. It's good for your whole body. And the recommendation that I want to give you here is to embrace a checklist of health measures that really are well vetted and have been out for a few years from the American Heart Association. You may not know this, but the American Heart Association is also the American Stroke Association, so they are interested in heart and brain. And there's even some evidence that adherence to these measures here can actually prevent you from developing cognitive decline yourself. So the organization that promotes these and makes them very user-friendly is the American Heart Association, and within their website, the catchphrase is Life's Simple 7. So there are 7 factors here that are listed across the bottom of your screen, and these are all heart health factors, and they are aerobic exercise, controlling your cholesterol, eat right, manage your blood pressure, keep your weight down, keep your blood sugar low, and stop smoking. And when I can actually see my audience and see the look on your faces, I know that a lot of people glaze over when I bring these up, or they start to roll their eyes. Well, we already know all these things. But the important thing to know about this is that even though we all know that these are the things to do to keep ourselves healthy, only 2% of the American population is meeting all 7 guidelines. So that's what's led the Heart Association to emphasize them. And it's true that there's some of these that you might need a doctor's help for. I've put the asterisks by them. You know, if your cholesterol or your blood sugar, your blood pressure are very high, you might need medication for some of them, and you should consult your doctor if that's the case. But some of these can be done on your own. There's aerobic exercise, eating right, losing weight, stopping smoking if you're a smoker. I really want to encourage you to take a look at the website that I have advertised on the previous slides. You can find this just by Googling American Heart Association or Life Simple 7, and you'll get a screen like this with the factors listed across the top. And if you click on one of those factors, so I've clicked on the Get Active here, this is about exercise, you get this information about exercise, including some specifics. And then if you keep clicking the items that say learn more, it gives you more and more detail about, in this case, exercise, even to the point of, if you keep clicking, and this is in the same website, it'll take you to walking paths in your own neighborhood. So this is really a remarkably user-friendly program that's oriented to improving your own health. And when I think about giving concrete advice to caregivers, I think this is a wonderful tool to use, because you can, in addition to using the website, you can also just sort of see where you're doing on these things. And this is a sample scorecard here, and it's showing that for this person, it's a non-smoker. Blood pressure is kind of marginal. It's not quite where it's supposed to be. This person, even though they're motivated, their glucose and cholesterol, they're not quite sure about. They're sort of making it on exercise. Their body mass index is a little bit high. So this is my scorecard, just to give you an example of even somebody who preaches this on a regular basis, who's really motivated, has a lot of work to do, and I think all of us do. So that's why I like to recommend this when I'm trying to give people a concrete way to take care of their health. So I think that concludes my comments. I think I'm maybe a little over time here, but I wanted to leave you with those 2 checklists, a 10-point checklist and a 7-point checklist. And now we'll come back to the polls, although everybody was pretty one-sided on this from the beginning. And look at this. All right. So we made the point that dementia is a broader term. Alzheimer's disease is one type of dementia. Parkinson's disease dementia is one type. Lewy body dementia is one type. And that's why the answer is that dementia is not the same thing as Alzheimer's disease. It's a broader term than Alzheimer's. Why don't we go to the next slide? So dementia is rare in Parkinson's. We already, I think, before my comments, you were pretty clear that it was rare, and now that may be even more true. In the interest of time, why don't we go ahead to the next one? Dementia caregivers at increased risk of poor health. This was one that I wasn't sure people were going to recognize in advance. You did, but I think it's even more one-sided now than it was before. All right, and then my last poll question, and this is for my own sake in some ways for the future. What information of what I've shared to you today, what will you use, do you think? So the checklist for the patient, the checklist for yourself, or did you really not find it to be very helpful? All right, good. Well, you know, I think the people, the numbers are still coming up here. I think people who tune into this and people who are caregivers usually are a little more concerned about the patient than about themselves. And one of the messages I was trying to convey here, and I'll restate again, is you really can't take care of the patient without taking care of yourself. So I'm glad to see that a lot of you feel like you'll be able to use that information. So I will stop there and pass it on to whoever picks up the ball from here. Thank you very much for your attention, and thank you again for the invitation.
Joe, that was fantastic. I really appreciate you taking the time to share with us. And I don't know if my video is back on, but ready to do so. Excellent. You know, I think what you did was really brought up a lot of really good points that led to some very good questions. And so just before I do that, I just wanted to mention a couple things. One is we have a number of viewing parties that are out there here in the US, and just want to give a shout out to them in Northeast Ohio, Cedar Rapids in Iowa, Omaha, Nebraska, and Overland Park in Kansas. Hello, everyone. And we have a viewing party in Kenya too. So welcome that group as well. And the nice thing about these webinars is it can reach people all over the world. So that's something good to keep in mind. And so, and if you know people who didn't get a chance to see this webinar, in a day or two, it will be archived on our website, and they can download it and listen to it themselves to catch up on any information. Or if you want to listen to it yourself again, you can do that. And speaking of timelines, just want a reminder, if you're a health professional and you sign up for CEUs, you get that 1 credit, but you have until the 5th of December in order to go in and take the test and claim your CEU. So I encourage everyone to do that. You know, we've got lots of questions. We'll get to many of them here, but if you have any outstanding questions, I encourage you to call our number, which is on the screen right there. 1-800-4PD-INFO. That's 1-800-437 4636. Sorry, I need my glasses. I don't have it quite memorized. And on the screen right here is a nice little thing about newly diagnosed. It's a new effort that the foundation is putting together. We have a lot of materials on that and just trying to put it together in a coordinated fashion to reach out to people who have been just recently received that Parkinson's disease diagnosis, because we believe, and I'm sure Dr. Quinn will echo this, that people who begin to educate themselves about the disease process, get involved with materials that our foundation can offer, will have a much better journey than if they do this alone. So, you know, when we talk about people who are newly diagnosed, Dr. Quinn, one of the things that I've come across here, some of the questions that people are asking is, what are some early signs of dementia? When do you know to go seek help from individuals who may begin to show some thinking processes, and what do you do to recognize it?
Okay, good. Well, I made the point earlier that hallucinations are often associated with dementia. They're not equivalent, but they're often associated with dementia. So that's a very evident phenomenon, and that's a phenomenon that you want to bring to your doctor relatively early on. The other types of problems are, forgetting very significant events or being unable to complete tasks that people were able to do previously. So that's often comes up when people are trying to file their taxes or trying to pay bills or trying to put a meal together. Something like that might be a significant change. So I think those are some of the most common complaints that I hear from people with Parkinson's disease with cognitive problems. The distinction from Alzheimer's disease, which is more common, is really the hallucinations. That's often the red flag that brings people to attention early on.
And is that a good way to differentiate the dementia we see with Parkinson's disease from dementia with Lewy bodies?
Yeah, so that's always a confusing point for patients and professionals alike. And hallucinations are seen both in Lewy body dementia and in Parkinson's disease dementia. The real sort of defining distinction between Lewy body dementia and Parkinson's disease dementia is that the movement symptoms predate the cognitive symptoms and hallucinations by years in Parkinson's disease, whereas they come on pretty well together in the case of Lewy body dementia. The hallucinations are also a little, the phenomena of the hallucinations is similar between Lewy body dementia and Parkinson's dementia. But in Parkinson's disease dementia, people are usually on, since they've had Parkinson's disease for a period of time, they're usually on doses of dopamine boosting medicines that are capable of promoting hallucinations. Whereas in Lewy body dementia, the patients often have hallucinations in the absence of any of those provocative medicines. So that's another distinction between the two.
And when we think about hallucinations, some other parts that go along with it, you mentioned the cognitive changes that can occur, can lead to changes in executive functionality. One of our listeners just wanted to ask a little bit more detail about that because they were thinking that some of these inabilities to plan and to do multitasking would be more representative of Alzheimer's. Do you see things like that in Alzheimer's versus Parkinson's?
You do, and it's a matter of relative amounts, right? So in Alzheimer's disease, the memory problem is a very, very dense memory problem. The patients with Alzheimer's disease fail to form a memory, and there's no recovering the memory. Patients with Parkinson's dementia do have memory problems, but it's not the same density, and it's often the sort of thing where some of the memories can be brought back later on. It's not a real dense amnesia. So you used the term executive function a second ago. So executive function is this set of functions that have to do with planning and sequencing and doing complex tasks. Multitasking is a term that we often use to describe a part of executive function. And those things fail both in Alzheimer's disease and in Parkinson's dementia. But in that case, the problem is worse in Parkinson's disease early on than in Alzheimer's disease. So it's a matter of the relative severity of these things in each condition rather than one being absolutely present or not in each condition.
Yeah, so I guess it's just timing is everything to help really kind of differentiate these two when it comes down to it. One of the things I thought was really nice, I think you emphasized, is that even though someone has dementia, it doesn't mean you shouldn't include them as part of the decision-making process. And It's a difference between consent versus assent. Because my understanding is that it would make everything become more agreeable when they are a part of the process and can see what's going on. And to the extent that they can understand it, at least they can agree to it and move forward. Is that am I accurate in what?
Yeah, I think you're on the money there, and it's a little bit of a fine line in that you certainly want to keep the person involved as much as you can. But for example, if they're unsafe to drive, but they want to drive, then they can't drive, right? So you have to draw the line at safety. And you know, I gave the example earlier about medication, and that maybe is a good example to keep in mind, that there are ways to try to ensure the safety of the person, but keep them engaged in the process at the same time. So the idea of using a pill box that you do together and monitor together is a way to keep the person involved, but also make sure that they don't get into a catastrophic situation. And in some of these other areas, maybe we can think of other examples. I can't come up with them right at the moment.
Absolutely. I think my audio may have just cut off.
I can hear you.
So just wanted on the screen is our sign about our allied team training that for Parkinson's disease, and just to let everyone know who's out there as clinician, we offer this national program a couple times a year to really bring health professionals together so they can learn how to operate as a team. And you know, Joe, one of the things you mentioned is you know, we talk about team care for a person with Parkinson's disease. Who's the best person as part of the team to really address cognitive issues? Is it the movement disorder specialist? Is it, you know, occupational therapists? You know, who to go to?
So, so the movement disorder specialist should be able to do the preliminary review and the medical part of things, and movement disorder professionals are uniformly able to do cognitive screening, and it's actually recommended once a year in people with Parkinson's disease according to the practice parameters. So it can start with the movement disorder professional, and then depending on the resources at the institution, sometimes there are neuropsychologists who can do more in-depth cognitive assessments, and many of the centers of excellence have that kind of expertise. Then there's also, within speech pathology, there's a sort of subspecialty of cognitive rehabilitation. So there's some speech pathologists, even though it's not what you would initially consider as a speech problem, some of the speech pathologists have special training in cognitive rehabilitation. And, and they can help people with not only a little bit of rehabilitation, but also what a lot of our therapists do in all these areas is compensatory strategies. They teach people how to cope with memory problems or organizing problems or that sort of thing. So speech pathology is what we use at our institution. Not everybody has that expertise. Occupational therapy can do a little bit of this as well. At our institution, it just happens to be speech pathology more often.
So, you know, I'm just thinking again about this hot button issue about driving. How do you, who would you involve to help evaluate whether someone is really capable of driving? Is it, you know, again, thinking about the team, is it someone like occupational therapist, is, you know, who I think might be more involved, or your neurologist?
Yeah, great question. So the therapy, the branch of therapy that usually does the driving assessments is occupational therapy. And occupational therapists vary a little bit in their enthusiasm about doing these sorts of things. But I like to use an occupational therapist in contrast to using a driving school who can do an evaluation, or asking the DMV to test somebody, the Department of Motor Vehicles to test somebody, because I like to keep it sort of medicalized, and we can you know, keep the information within the sort of medical setting and make the decision within the medical setting. And I find that patients accept that a little bit better. It's always hard to give up driving. I mean, imagine any of us listening, if you're a driver, giving up driving would be a terribly difficult thing to do. But I think if you've got if the doctor can say, look, we want to make sure that everybody's safe, the way that we'll do that is that we'll have you evaluated by an occupational therapist, and then we'll all agree in advance that we're going to honor whatever the occupational therapist says. Then I think that's an acceptable process for a lot of patients, whereas reporting them to DMV or having them go to a driving school and getting an evaluation is a little less acceptable. Now, there's also going to be times where safety has to trump things, and the doctor has to make the call that the patient cannot drive. And some states allow the doctor to report that to the DMV and have the license terminated. that's a tough thing to do and has damaging effects on the doctor-patient relationship. But if people are at risk otherwise, sometimes you have to do it. So, so there's a whole range of things. And like I say, I prefer the occupational therapist. There's a couple of other options available. And then in some situations, we have to go to extremes a little bit. Does that answer?
Yeah, I think that's a great answer, Joe. And, you know, it touches on another point, you know, when we talk about dealing with people with dementia, there sometimes can be emotional components to this as well. So how do you, so I can imagine, as you mentioned, people really not wanting to give up their driving, even though there might be evidence to suggest that they should. They become angry. How do you deal, maybe not always with, you know, this situation, but just emotions in general, anger, anxiety for a person with dementia?
Yeah. Okay, so as a general rule, now I'm going to talk about people who are not at the mild cognitive impairment range, but really are sort of at the range of dementia. They're a little more impaired. We've tried to keep them as involved in the decision-making process as we can along the way, but now we're at a point where they're pretty impaired and they're having problems with anger and emotionality and that sort of thing. The best advice I can give people is you do not want to engage them. You do not want to try to reason with a person who is at that level of the struggle. But what you can do is redirect them. If you can redirect the topic to something a little bit different, particularly if people have a pretty good memory problem, you can often diffuse the emotional situation without too much trouble. But when you sort of engage and reason and so on, you can sort of go down a path of no return and aggravate the emotions rather than resolve them. You know, the hard thing about that, it's easy for me, advice for me to give as a doctor sitting in the office. I know, you know, what happens is we're dealing with somebody we've spent our whole lives with and they push our buttons in certain ways, so it gets a little tricky. And that's when I was talking earlier about getting education about communication, it doesn't come naturally. This practice of redirecting and reassuring and that sort of thing. And that's where some of these educational programs can be very helpful in helping to manage those things. You know, there's always the possibility of physicians using medications to calm people down when they're having those problems. But I think we all recognize that we would prefer to avoid all the side effects of those things. And if we can teach people how to interact with the patient a little more effectively, that might allow us to use less medications in that respect.
Yeah, I think that's a really good point that you bring up. You know, we have sometimes reliance on these medications, and it's not always a positive thing. You know, just want to, you know, since you mentioned communication, our previous and inaugural expert briefing for the series was about communication. So I encourage listeners who are listening to our dementia presentation to go and refer back to that one. It's online and has a lot of useful nuggets. Even if you are not having to deal with someone who's living with dementia, it's just really great information on how to communicate together as a family. And I think that's really important. On our screen right now are just some resources for those in the community or listening. We've got our helpline again. Download materials available. There's a podcast for those who may be driving and can't necessarily look at something. And then again, our wear and care kit, which is incredibly useful for those who may have Parkinson's disease and be facing entry into a hospital, whether through elective surgery or for some other reason to go into the hospital situation. You know, just we're running down on time here. We're at the top of the hour, so I don't want to keep you much longer. But I do have another question for you, and that is regarding people who are worried when they see a family member who has dementia. They think about themselves. What do we know about the genetic links between dementia, at least within the Parkinson's realm? I may be able to speak about Alzheimer's as well, but it'd be interesting to know.
Yeah. So we know about a couple of genes that in the setting of Parkinson's disease are associated with dementia. One of them is the GBA gene. It's the gene that's associated with Gaucher's disease and is also associated with Parkinson's disease. And some of the audience has maybe heard about this before, but this is something that just came to light in the last 15 years or so, that this is a gene that's associated with Parkinson's disease, and it is present in a minority of people with Parkinson's disease. The Parkinson's-associated variants are present in about 4 to 8% of people with Parkinson's. And that varies depending on ethnicity of the group, but 4 to 8% is a good ballpark estimate. If people who have that gene not only are at increased risk of Parkinson's disease, but in the setting of Parkinson's disease are at increased risk of dementia. So it's relatively rare, and it has become, as you know, Jim, a big focus of clinical trials. That it's a molecular pathway that is well understood, and there's a lot of exciting research trying to intervene with that particular group. So, so when you ask about genetics associated with dementia and Parkinson's disease, that's one of the key items to bring to mind, although it only applies to a minority of people with Parkinson's disease. The other gene that in the setting of Parkinson's is associated with a gene called ApoE for short, and it's ApoE4 in particular. So that's a gene that we've known for a long time has been associated actually with Alzheimer's disease. The gene itself is not associated with Parkinson's disease per se, but if you have Parkinson's and you have the gene, there's an increased risk of developing dementia. And that gene is present in only about 15 to 20% of people with Parkinson's disease, which is the same prevalence in the general population. So again, it's a minority of people. So I'm answering the question that you asked me, which was you know, what genes, what do we know about the genetic contribution to dementia and Parkinson's disease? But I think I'm going to add to the question, you know, what can we do about it right now? And right now, even though there's a lot of exciting research, as I was just mentioning, we don't have gene-specific recommendations. So we are not routinely recommending that people have genetic testing for these things if it's outside of the research arena. And when I think about dementia prevention in general, I think that last 7-point checklist is the one that I push to people since we don't have something linked to the genes right now. I think in the future that'll change, but we don't have that right now.
You know, I think, Dr. Quinn, you bring up a really good point here, and this is something that we've addressed. As you know, the foundation has an effort called PD Generation, which offers genetic testing for PD-specific genes for people who are already diagnosed with Parkinson's disease. But as we looked about the different genes with which to consider testing, ApoE was one of them, and we decided not to test it because there's nothing actionable about this gene. There's no disease treatment that's on the horizon. GBA is one gene we do offer testing for because there are studies which are getting ready to go live. Some of them actually are, which may make a difference. So, you know, we felt as a foundation that if there was something you could do about you know, some of these genes that getting tested for, then it might be worthwhile to do it. But I think, you know, overall, what we come up to is that people need to make an informed decision on their own, you know, how to move forward, especially around things that they can't do much about because of the path that they're on, but there are some for the others. You know, Dr. Quinn, I want to thank you very much for your time. And the audience, just to let you know, we're going to have a poll coming up at the very end, survey, different, not a poll, but a survey, just asking for your feedback about this presentation that Dr. Quinn, which was, I believe, fantastic. And, you know, we also want to highlight the fact that we have another extra briefing series, which is coming up in January 2020. It's going to be about optimal exercise strategies for stability, stamina, and strength. And it's going to be by Dr. Joellen Fox, who's a lead therapist at the Good Shepherd Penn Partners and Rehabilitation Center in University of Pennsylvania. So For those listeners, as you close out of this webinar, there'll be that survey. Please take it because we utilize that information so much in order to improve our series, and always are listening to the, our community on how to address their needs. Dr. Joe Quinn, thank you very much for your time today. It was an excellent presentation. And to everyone out there, I'll see you again in 2020. Take care.
Thanks very much.
Bye-bye.